Dr. Goadsby is one, and we're in very privileged company to be able to have Dr. Goadsby. He's one of the world's leading neurologists, researchers, and specialists in the field of headache and migraine. He's published hundreds of different journals over his career. He is a prolific researcher. He's involved with leading migraine headache entities and institutions in the US as well as in the UK. He's a trustee of the Migraine Trust. He's the president of the American Headache Society, and he's also been a president of the International Headache Society, which is pretty much the World Health Organization equivalent for a headache organization globally. I don't think there's any accolade that Dr. Goadsby has not achieved in his career, and so we're very fortunate to have him with us here tonight.
I was asked to talk about what's new and interesting in research in the broad context of treatments of migraine. So necessarily, if there are things that I don't mention or things you don't think are interesting or treatments you think are irrelevant, it's a personal view. And of course, all of these things, new and interesting, is a very personal thing. So it obviously depends on how your mind is thinking at the time. So most people would know that there are other types of headache other than migraine. And this is the list from what just being described as this is the International Headache Exercise Classification. So if it's the canonical version of what it is, so to speak. Now, it's like everything else that people do. It's a reasonable document, and it's a thing that's in evolution. I simply wanted to point out with this that while migraine dominates the scope, it's not the only type of headache that occurs. And if there are any of you who are on the line who fit into any of the other categories, fine and dandy. I am going to say something about medication overuse, because it's something that often patients get pilloried about, the amount of medicine they use and the consequence of that and so on. And people are pilloried in a way as though we actually definitively know what's going on, and that's really far from the facts. One of the things I reflect on when I think about this classification, which I think is interesting but it isn't new, is how we've come a long way in, well, a relatively short time. The classification's been around for some years now, but it's a short time in the history of man. From calling migraine hemicrania simplex, which is just so much not a very good description among the others. Common is also a terrible description, to this classification system, which has inherent weaknesses itself. And I think that sometimes we forget how far we've come in our lifetimes, so to speak, on a condition that's actually been around since forever. I mean, since hieroglyphics were written. It's likely that this has been a problem. When I think about migraine, I think about, and some of these slides are too detailed. And some of you will like the detail and some of you won't. So take that with a grain of salt.
Sorry, Dr. Goadsby, some people do like the detail, and so much so that they would like to request if you could click on the hide
down there.
underline. Yeah, because they're trying to read all the text. Great, thank you so much.
My apologies. I'll try and get better with this platform as we go. So when people use the word migraine, it's worthwhile saying, and I often say it to my colleagues, that the word itself is used in more than one way. It's used to refer to attacks, as in you're having a migraine. And what I showed you previously, this classification system, is largely describes what it's like to have a migraine: one-sided, pulsating, severity, worsen with movement, light, sound, sensitivity, nausea. It doesn't so much describe what it means to have the disorder migraine, as in, or disease. You have migraine because you have migraine, so to speak. When one's talking about the disorder, we divide it up into episodic and chronic. We use 15 days a month as a way to draw a line in the sand. And make no mistake, it is a line in the sand. Its only explanation is that 15 is half of 30, and otherwise, if you think that doesn't make any sense, it doesn't make any sense to me either, and I signed up to it. Migraines has, as a disorder, as a prominent family history, and the well-known things that are often discussed, these triggers, ways of turning an attack on. Now, I'm sure that alcohol and nitroglycerin turn attacks on, and I'm sure that hormonal things are associated with migraines, such as menstruation. I've often heard that weather is associated. Things like light and sound and sleep or disorder and skipping meals and so forth are all have become really interesting when you start to think about trying to unpack what's going on. And the reason behind everything I'm going to say is to understand is to improve. We'll never get good at migraine if we don't understand it in real detail. At the moment, the diagnosis is based on what patients say and to some extent how physicians hear it, and they're not necessarily the same as probably people have had the experience, and that's weak. Although on the other side of it, it's cheap. You can apply that history taking anywhere in the world, and treatment, of course, needs to be based on understanding. Now, when I think about the stages of migraine, classically people talk about the beginning part, the premonitory aspect, the pain part, what I've called canonical here, the symptomatology we've just discussed in terms of definition, and what comes afterwards, the post-drome, feeling absolutely like your batteries have completely flattened out. I put some of this in grey because there are things that happen clearly, like the cranial autonomic symptoms, redness in the eye, sniffliness of the nose, drooping of the eyelid, that occur before that can occur with the pain and can occur before it. And there are features that occur with the pain that we don't include in white in the definition, but they're just as lively. Things like sensitivity to touch, allodynia, the pain with a non-painful stimulus. It was actually very well described by Jim Lance and George Selby in Sydney more than 40 years ago. This symptomatology is very common. We see it perhaps in 4 out of 5 people that we see, or a little bit less than that, but it's not part of the definition. Now, one of the things which is I'll probably say interesting on almost every slide, because I'm a bit of a dilettante, so excuse me if I overuse the word, because I think everything about this is interesting. What has become important is our ability to image the event. So you can trigger a migraine with nitroglycerin, for example, and you can show areas of the brain, these little orange blobs that are active in here and in back parts of the brain that are active during the premonitory phase. So the tiredness and sleepiness, yawning, concentration problems, the sort of things that happen very commonly in the premonitory phase before pain onsets. That's why I've got the lined up the way I have, are just as real as pain or anything else that's happening in migraine, and can be just as disabling. What's becoming really obvious is that all this symptomatology mixes together. So you can have light sensitivity before you get head pain, or you can have it with it, or you can have it very rarely afterwards. You can have this sense of concentration impairment, brain fog, you might say, beforehand, and very often persist with the attack and can persist afterwards. It's become complex. It always was, but our understanding of it's getting that way. And I think of this in terms of what are called networks, so connections of things in the brain. And we can image these networks. And effectively on the left of the screen there is what we're doing is imaging a network of migraine during the premonitory phase. On the far right, what we're doing is looking specifically at the pain phase and seeing areas of the brain, like this little blob in here, which is in a structure of the brain called the pons, and this little blob in here, which is in a structure of the brain called the thalamus, which will be offered as a reasonable explanation for many of the things that we see going on. Now, what's focused us down on this is using another technique, which is a magnetic resonance imaging, or MRI technique, that allows you to see parts of the brain active during the premonitory phase. I'll focus here on, for example, it's called the orbitofrontal, orbit because it's near the eyes, frontal cortex, which is active during the premonitory phase. And you can pair out the premonitory phase into various sections, you might say, or broad concepts. So you've got higher center things like tiredness and mood change. Neck discomfort is very common. And what you could call homeostatic, which are symptoms that are that are involved in parts of the brain that normally keep things stable, you might say. So we eat, we drink, we pass urine, we sleep. These are all pretty fundamental activities, and they happen from parts of the brain that we don't necessarily directly control. They're automatic at some level. We think of them as homeostatic because they maintain balance. And when you start to put all these together, it already sounds very, I haven't mentioned pain or any of the other symptoms. It starts to get very complex. Our understanding of this gets much better as we're able to image parts of the brain, these little red blobs that are involved in those symptoms. Now, late last year at the International Headache Congress, seems like forever away before COVID-19, we presented some data, which will come out of a journal shortly, that asked ourselves the question, if I say food cravings as an example, or skipping meals, changes in appetite, and I say it from a trigger perspective, very often meal skipping will be cited as a trigger. If I then ask someone about their premonitory symptomatology, hunger, tummy problems, tummy discomfort is very prominent as an association of the symptoms that just happen before headache. In fact, the agreement between the two in an individual, as you see, is 80%. The agreement from people who say, well, if I relax from stress, it triggers my headache, is about 90%, with a sensation of elation in the premonitory phase. This one's is a little less obvious. It's only 66%, but I think that may be a little bit the circumstances in which we would do it. But it's the idea that if you have the bright light may be a trigger, whereas during the premonitory phase, the patient will mention photophobia. So we're starting to develop the idea that some of what have been called triggers are actually the earliest manifestations of the disease, because these premonitory phase symptoms can happen hours and hours and hours, up to 2 days, up here, 2 to 48 hours before the attack. You have to ask yourself the question whether some of what's reported as a trigger is actually simply the premonitory phase. Now, the consequence of that, firstly, begin understanding is useful, but the other consequence of that is you obviously, the attack has started. So trying to avoid or change things where the attack already starts is simply is frustrating, as many people will have experienced. This trigger avoidance not really leading anywhere. Now, I don't think all triggers are explained by the premonitory phase, but I think understanding some of the disconnect between trigger manipulation and headache control is explicable by understanding the premonitory phase. And it's not just made up in the sense that, I'll take the picture on the right. If you take people in the trigger and you trigger an attack, and you compare the ones that have light sensitivity during that premonitory phase with the ones that don't, then the area of the brain that lights up is the back of the brain here, which is the vision area of the brain. So it's the perfect anatomical correlation, a perfect structure, if you want, that's involved in the earliest phase that would predict that you'd be sensitive to light, which makes it's exciting to think that these things make sense. Now, if I want to dig down into one of these, and to illustrate that what lab people and researchers are doing is trying to dissect out these various symptoms one at a time to understand them. It's like taking a puzzle to pieces, taking something to pieces, working out the problem so you can re-put the puzzle back together again with a way to change the outcomes, you might say. So understanding breeds outcomes. And it revolves around, some of this revolves around something called orexins. Now, orexins are made in a deep part of the brain called the hypothalamus. They come from one gene. There are two of them called orexin A and orexin B, and there are two receptors called the orexin 1 receptor and the orexin 2 receptor. So it's not terribly tricky nomenclature, the way of describing things. These orexins are known to be involved in feeding, sleeping, hormone regulation, and pain processing. So that's a pretty nice place to start thinking about them. And we've looked at these their manipulation over a number of years now, and they clearly can change the way pain processing is done within the brain. What I want to do is bring your attention to very recent work, again from the International Headache Congress last year, taking advantage of molecular biology techniques, ways of manipulating genes and manipulating structures within the brain to ask the question, if these orexin neurons weren't behaving properly, and here they are all stained up, orexin A and orexin B all stained up in fluorescent green, and you can develop a mouse in which you can knock those orexin neurons out literally by a local injection into this part of the brain. You can see very convincingly that that orexin can be knocked out in these so-called Cree animals. Now, a consequence of knocking that out is the places that the orexins talk to in the brain, and here's a specific one. This is what it looks like normally, but when you knock them out, obviously, it's not talking to that area of the brain. Okay, so why would we be interested in that? Because if you simply knock the orexin neurons out, you make facial responses more sensitive, mechanical sensitivity. Now, push the envelope of consideration forward a little bit. What I'm talking about is being able to generate a phenomenon that's just like allodynia, just like the sensitivity that migraine patients get when they touch their head during a bad attack, the discomfort. You can reproduce that by starting to manipulate these orexin mechanisms. So you can start to understand why, if there is a disturbance in this system, you predict that a good proportion of people would end up having this discomfort when they touch their head, so-called allodynia, and that it gives a pathway to trying to piece back together the various symptoms of migraine. Migraine aura, about 25% of people, depending on age, it's this jagged lines that appear in the vision that grow. It's called a fortification because it looks like a fort. Well, the way they used to make forts in Europe in the 17th century. At any rate, it's an accident of history that's why it's called fortification spectra. And associated with it are changes in the blood flow in the brain. Blue means a reduction. This is starting small and it's growing. And you can track that across the brain as others have done. So we've got a fair idea of what's going on with migraine aura. Now, a terribly important insight into migraine aura came several years ago when a type of aura, hemiplegic migraine, weakness down one side of the body, that ran in families, so familial hemiplegic migraine, was the gene was cloned. It's got a fancy name, CACNA1A. It's a type of gene that alters a structure in the brain that is sensitive to voltage, to electrical signals, and it can make if you knock that gene, if you make an experimental animal have that gene manifest, a human gene in the animal, then you can change the way a phenomenon called cortical spreading depression, a wave of change in the brain that's moving across the brain, and it's moving across the brain rather like this flow change that Olison described all those years ago. So you can actually then work with that species to understand the biology of the problem. Now, what's new in this is linking together a human observation with aura in another mutation. There's a condition called familial advanced sleep phase syndrome. It was discovered years ago, and astute neurologist Bob Shapiro in Vermont saw a family who had migraine with aura and also had familial advanced sleep phase syndrome. He worked with Louis Potacek at UCSF and Andy Charles at UCLA to characterize this. Now, it turns out that the mutant gene that's responsible is called casein kinase 1 delta. Name doesn't matter so much. But the mutation causes people to advance their sleep, their phase. And what these people do is they think it's great to get up at 3 o'clock in the morning. They're absolutely bright-eyed and bushy-tailed. And by 6 p.m., they've had it, they're shifted. They're very successful in the, you might say, in rural communities and feel perfectly well. And so you can knock this mutation into a mouse. And so you can start to study how the mouse brain behaves when it has the same gene mutation as humans do. I'll draw your attention to a couple of things. This work of Lawrence Strothers, who's just finished her PhD work, primarily supervised by Phil Holland at King's. You get, if you compare the CK1 delta, these mice with this advanced sleep phase mutation that will cause migraine aura in humans, they get more cortical spreading depressions when you stimulate them over an hour than a mouse without the mutation. So what this does is link together this mutation to the previous mutation I was describing, the PQ voltage gated calcium channel mutation. Why obsess about that? Because of sleep. Many people who will recognize that poor sleep, lack of sleep, irregular sleep is a migraine trigger. And how can we start to relate those two things? Well, you start to think of them in terms of sleep regulation. Just changing sleep regulation can change the ability of the brain to get cortical spreading depression, aura. And you can show at the bottom here, bottom panel, that if you take these mice and you look at their mechanical threshold, that is if you use a little, what's called a von Frey hair, and you see how sensitive they are to that hair, that the mutant mice and the wild-type mice are the same, unless you actually give the mice an injection of nitroglycerin. It doesn't make a difference to the wild-type mice, but it vastly, remarkably lowers the sensitivity to that stimulus in the mice that have the mutation. And unsurprisingly, some of you might know already, that if you infuse nitroglycerin into people with migraine, about 80% of them will develop a migraine, and about 2/3 of those will have this allodynia, this abnormal sensation. So what we have here is a model that links together sleep alterations with the aura phenomenon and with the biology of a pain phenomenon, that is to say, the nitroglycerin response in humans. So if I was to talk, just to say a few things about the pain, I want to try and again make a link into between pain and aura. Pain activates various areas in the brain, but a particularly prominent area is this area. This is called the pons, and this little blob, these little blobs. This is the first blob that Weiler described many years ago. This is a lesion producing migraine. What's in common here is whether you've got nitroglycerin triggered migraine or you've got spontaneous migraine, this blob area gets active. Now, one plausible way to think about this blob area is to think it might be a structure in the brain called the locus ceruleus. This contains about 9 out of 90%, 95% of a substance called noradrenaline within the brain. And the locus ceruleus is terribly important for regulating things that you're going to think are a bit of a broken record now: sleep, pain, and sensory attention. It's involved in what you focus on, so to speak. So we asked the question, or Marta Villa, again working with Phil Holland, asked the question, what happens if and we're looking for ways to link migraine aura and head pain without just thinking that aura doesn't turn on head pain, but that it's involved, it's linked up in a process, a series of dominoes, you might say, that fall. If you take out the locus ceruleus here on the right-hand side compared to the left, with a chemical that disrupts locus coeruleus neurons, then your ability to trigger cortical spreading depression is lowered, and the number that you get of the cortical spreading depressions is increased. Sound familiar? Same sort of thing as what I was describing here, number of CSDs increased. This is a mouse with changed biology, and what we're describing here is an animal with changed biology but with normal underlying genes, so you can simply manipulate these pathways. So you can show that if you get changes in areas that plausibly we know to be active in migraine, that are involved in pain processing, trigeminal pain processing, head pain processing, you can link that into the aura process by thinking about these structures and their dysfunction. And this side, what we're doing is looking to manipulate that change using a chemical, clonidine, and a blocking chemical called yohimbine that acts at a very specific place, what's called the alpha-2 adrenoceptor, to understand the pharmacology, the possible drug targets you might have, to normalize, if you want, when there's dysfunction within this area called the locus coeruleus. I want to turn my attention a little bit to CGRP. It's hard in 2020 not to think about calcitonin gene-related peptide because it's of the therapies that are being developed, and it's hard to not think about the overarching question that's been in play, well, for most of the last 50 years, which is the extent to which you have to constrict or narrow a blood vessel in migraine to have an anti-migraine effect. Do you need to do that? Because if you don't need to play with the blood vessels, that's a good thing for anyone of you who've been denied a triptan, for example, like sumatriptan, because they've got a cardiac heart problem or had a stroke in the past. The reason for that is people are nervous about these drugs affecting blood vessels. Now it's emerged that you can alter this pathway, this pain pathway, by manipulating the receptors or targets on it. And one of those targets is the so-called 1F serotonin 1F, 5-HT1F receptor. It only sits on the nerves. So it begs the question whether you could develop medicines that only have that don't have a blood vessel effect, just a nerve effect. You can show in a couple of ways. You can show that you can turn off trigeminal neurons with a 1F effect. You can show specifically that a drug, I'll show you some results on, lasmiditan, does this to trigeminal neurons. This is Marta's work again. And you can show that some of the triptans have a 1F effect, naratriptan, for example, or L-triptan, but some don't, like rizatriptan. Most importantly, in many ways, you can show what these 1F drugs like lasmiditan does to blood vessels. Nothing. So that's a way forward, and it tests the so-called nerve hypothesis. To cut to the chase, it's become clear in the last year that compared to placebo, the inactive tablet, that lasmiditan, 1F agonist, is effective in migraine. It's very, very potent at this receptor. A concentration of 2 nanomolar compared to 1,000 at the so-called triptan 1B and 1D receptors. You can see the difference is really gangbusters. It's clear that we can block these receptors and turn off migraine. So the direction of traffic is very what's called neural. Certainly some patients get dizziness and somnolence. Nothing's perfect. But the important thing, however, is the broad message that we can get better treatments by understanding what the best biological target for the treatment is. Now, specifically, CGRP is released from these nerves that are important in migraine, and certainly the 1F agonists are probably, like lasmiditan, are probably blocking that. The other thing that's been tested and clarified in the last couple of years is what happens if I was to block CGRP, calcitonin gene-related peptide itself, for as an acute, would that stop the acute attack of migraine? Because again, these CGRP receptor blockers don't constrict blood vessels, they simply block the effects of CGRP. And there's a lot of pictures on here, but I want to emphasize that there's thousands of people been in studies with this drug is called Orexinergic that show that it produces an excellent pain-free effect and reduces the most bothersome symptom, light or sound or nausea, at a very modest price in terms of side effects. Across 1,700 people in these studies, got 1.5% having some nausea and 0.8% on placebo, with really nothing else going on. These are incredibly well-tolerated medicines that are now available in the US. Its cousin medicine, if I could call it that, is called Ubrogepant. They're all called G-Pants, G-P-A-N-T. That's the class, just like sumatriptan is a triptan. Ubrogepant and Orexinergic are G-Pants, and the same sort of results. The results are more or less identical. They could have just taken a pen and paper and written them down. I'll assure you they didn't. And the outcome's the same. There's barely any noise between the nausea outcomes in placebo and in the active medicine. Very well tolerated, very safe medicines that are rolling out. And it hasn't finished. The next one that'll come along was called Vascular for a little while, and the name's changed now so forget that. By the time you see it, it's going to be called Zavegepant, because the naming people wanted to do that. And it's being developed in a nasal spray formulation to have, again, this anti-migraine effect and have this very safe anti-migraine effect. Now, one of the things you would have heard a lot about in recent times is the monoclonal antibodies to CGRP. And I just want to give you a sense of where they came from. They didn't come from nowhere. What happened was that there was much work that was done to show that CGRP was important in migraine. And for acute treatment, one drug that was developed was called Atogepant, and it worked in acute migraine, just as Orexinergic and Ubrogepant had. And what the company did was to take that into a prevention study, and instead of use it for acute attack, to ask yourself, well, if you took it every day, would it improve things? And the answer was yes. This is the comparison with placebo and active for 2 doses. It was effective. However, one of its metabolites, one of its breakdown products in the body, stirred up the liver and caused problems. So the drug was killed. But this proved the principle that if you block the CGRP pathway, you can have an anti-migraine preventive effect. And that's where the monoclonal antibodies came from. Because the monoclonal antibodies have the ability to specifically block the pathway without the downside of any of the liver things. And I'll just, the most important studies, I think, really, that have come out are the studies that have been done in people who failed previous preventives. Because the group of people who need treatments are people for whom current treatments don't work. Like, that seems like axiomatic. And there are 3 good studies now called Liberty, Focus, and Conquer, which each show, compared to placebo, that the medicine is better, be it urenumab, fremonizumab, or galcanezumab, for people who failed previous preventives. We found an interesting thing out as time goes on with these studies. You look at these what are called placebo rates. If you compare the placebo rates in people who've never had a failed medicine before, 33 and 38 here, with those who have had a failed medicine before, 11 and 14, it's pretty clear that the people who fail previous medicines have a much lower expectation of what's going to happen, unsurprisingly, and are really not only the best people to be involved in these studies, but actually they're the perfect target, because the ones that we want to make better. Now, what's got around the corner, and we just saw announced a couple of about a month ago now, the AbbVie press release on Atogepant. So this harks back to what I said about Atogepant, an oral medicine developed. This was developed specifically for prevention. The first study here came out in the Lancet Neurology about a month ago, more or less. And the second study, a larger study, has just been press released. And the bottom line is that you can block this pathway, So go back to the tablet idea and block this pathway with a once a day tablet, 10, 30 or 60 milligrams of Atogepant a day. They have really quite substantial response rates. So you've got north of 60% of people having half of their attacks go away and paying really minor, few percent penalty in terms of nausea and fatigue. Interestingly enough, up to about 7% with constipation, which is something that's emerged from the monoclonals, and no real liver enzyme problems. So that's where that is headed. In the last few minutes, I want to talk about acute migraine treatments and this medication overuse. So medication overuse is the concept in the way physicians use it, is that you have a certain number of headache days a month, 15, and you overuse a medicine. And we define the overuse in very specific ways in the classification of headache disorders. So regular intake of a triptan, 10 days on 10 days a month, paracetamol 15 days a month, non-steroidals 15 days a month, opioids 10 days a month. And we say that as though that's a known thing and it's a rule and it is what it is. But you might expect that for anything human, all the rules need their edges. And some of this has never been really clear in my mind, I have to say. It's perfectly clear in my mind that some people do badly if they're taking opioids like codeine every day, or if they're taking a triptan like sumatriptan every day, but not everybody. So throwing everyone in the same basket here is not very helpful. Now, all of this came in various ways. One of the nicest studies was Bigal and Richard Lipton, who showed that as the monthly use of opioids goes up, here in these curves, the chance of having more headache the following year goes up. And triptan's the same sort of thing. There's this prediction that if you do that, things will get worse. I was struck by this study called the MAST studies. Again, Richard Lipton was involved, and Todd Schwett out the leadership of this. This is a migraine treatment longitudinal cross-sectional study in the US. So they got people who had headache in the previous 3 months, and then had used some sort of acute medicine, and looked at the people who were defined as having medication overuse by ICHD, not in any pejorative way, but simply to say that's where they fit the definition. So they had 13,000 people in the study, which is quite good. About 15% of migraine patients fitted the medication overuse criteria. Now, if you compare non-medication overuse people to medication overuse people by their definition, and then you go back and ask what they're doing, you can see that they were more likely to be taking a triptan than overusing a triptan than the non-medication overuse group, and more likely to be taking an opioid. It's about double the ratio there, and it's about triple. That's about what we think, that you've got that opioids are highly likely to increase the chance of causing a problem, and triptans certainly do, but not as prominent as opioids. Interestingly, non-steroidals didn't do that. Naproxen, ibuprofen didn't do that. I have to say that's always been a question in my mind. There was a slight hint, in fact, and because of the large numbers, it was significant, but there's a very small hint that the regular use of non-steroidals was actually helpful. I'm not advocating going out and doing that, but I raise it because it goes to show you that as research evolves, your ability to hone down the message, so to speak, improves. Now, medication overuse people, that is by definition, had more headache. They had more migraine if you had the sort of symptoms together, and they were more likely to have allodynia, but only if they were males, interestingly enough, for which there's no explanation. So what's going on in the laboratory in this? Some recent work that's just come out in a journal called Brain. Yao, who was in London, hailing from Bangkok, and led by Phil Holland here, showing that all things are not created equal in this respect. So this is sensitivity. These are thresholds to withdrawal in an animal. So this is the control in black, and this green line shows you what happens if you have sumatriptan given every day. This is effectively a medication overuse scenario, and the animal becomes more sensitive, more allodinic, just as humans do. And interestingly enough, if you use a medicine which interacts with a 1F receptor like lasmiditan does, you get the same effect. However, if you compare the control with a Gepant, Orexinergic, the one we use, it's used in clinical trials, not used anymore clinically, with, again, sumatriptan, the Gepants don't seem to do this. And that's really important for understanding why you can take an acute attack medicine like a Gepant, and then you can use it in a preventive fashion and it works. Most of us wouldn't ever say to someone, take sumatriptan every day and good luck, because we think that a proportion will get worse. And I've shown you a little bit why we think that. With the development of Gepants, we're starting to find ways and mechanisms that can interrupt migraine, both attack and in a preventive sense, without making things worse, which is a huge development in that fashion. So it's pretty cool where we are at the moment at some level, because we've moved forward, and our shopping list, you might say, of things we can do now in prevention is really starting to evolve out. We know that patients don't like most of the medicines they have, and I don't mean it in some sort of don't like it because it doesn't taste good. I mean don't like it because they're not effective or they produce dreadful side effects. And we've got a lot of old style drugs that we've had for some time. We've got now the monoclonals, which are slotting nicely into treatment. We have some neuromodulation approaches, and as I've shown you, we've got these even newer medicines, these tablets, the Gepants, that are coming along. I think it's fair to say that as you marry together understanding the problem and the biology that goes behind that, you can make real developments and real advances in managing what's a really horrible problem for many people in a much more efficient way, without asking them to select from a horrible choices of side effects. I tell my colleagues there's just nowhere better to be at the moment than migraine, because there's just so much on and so much ability with the techniques we have to make things even better on a year-to-year basis.
Dr. Goadsby, thank you for sharing a lot of that information about the pathophysiology of migraine, as well as some of the latest new treatments and potential pathways for treatment. I think a lot of the people who've been part of Migraine and Headache Australia as a community would really appreciate that presentation not being dumbed down for them, and really sort of speaking to some of the science behind what's going on with the new treatments. For those who are brand new, it might be a little unusual to see those types of charts and graphs, but rest assured we've got articles and information all throughout our website that can get you up to speed pretty quickly.
I don't like to dumb things down, actually. I think that that people with migraine ought to understand that it's not smoke and mirrors that's going on. There's a real detailed appreciation of what's happening. And I mean, it's important that they understand that. Equally important that colleagues, everyone understands, there's a very, very serious problem with a really, really rich biology. And as you unpack it, things get better. Absolutely.
And so we'd encourage everyone, if it was a little bit of if the science was a little bit overwhelming, to catch up by referring to some of the articles on our website and that we've been sharing via emails. But to jump now,
let me say one other thing that about the it is overwhelming. There's no doubt about that. And it's okay if it takes you a while to understand stuff like that. I've been at it for 30 years, and there's stuff I don't understand. So it's okay to take a while. So I'm a bit slow. So just be patient and understand the bits that you want to take away. Is the way forward.
So one of the questions we had was from Umer, who said, "Can someone have migraines all the time, continuously, and 24/7?"
Yes, that would be a simple way of saying that. There are people who have one migraine attack a year, and there are people for whom migraine never goes away. The way I think about it is water bubbling on a stove. It can bubble around, and then it can bubble up, but it's always water and it's always hot. And yeah, there are people whose migraine, these mechanisms, these areas, these blobs in the brain I've been showing you, the same blobs are turned on largely when someone's attacks are there all the time. This network is active all the time. So that's a big yes. It's not, I mean, that's terrible. It's terrible. And it's a terribly, terribly difficult problem to deal with, but not impossible. We're seeing patients responding to particularly these new therapies who've had migraine every day. In the start, as we start to sort of turn the gas on that oven down.
So you talked about triptans and medication overuse, and then you also spoke about the new class of treatments coming out that can help potentially treat acute migraine attacks, such as the dietans and the Gepants. Can you talk about the risk of medication overuse with triptans and what might be a safe threshold for usage, and how that may be different in some of the newer treatments that we're seeing?
Yeah, so the safe threshold for any individual is your threshold, which is a bit dumb, but that's true. So a good way of mapping a threshold for overuse is that overuse with time, headache frequency goes up. So if you have a diary and you use, let's say, I'll say a number which is at the margin, but it'll illustrate the problem. If you use a triptan on 3 days a week this year, and you go back in your diary and you're using it on 3 days a week last year, then the chances are that there's not a problem because there's no escalation. I showed you that Bigal, those graphs. What overuse predicts is that things get worse year on year. So if you're stable, whatever dose you're using, it's unlikely that that's a medication overuse problem. Broadly speaking, I'm going to, there's some broad brush of what I said. If you take triptans daily, they weren't designed for that, and they'll produce other problems, like they'll tickle your blood pressure up a little bit. So that's a bad idea simply because it's just medically a bad idea. But if you're talking about the threshold for pain, firstly, look at what's happening over time. Our broad guidance, if you just put some lines in the sand, is to not use these medicines on more than 2 days a week, broadly speaking, because the problem where the curve takes off is somewhere around 10 to 12 days a week. The curve starts to take off. So if you stayed at 2 days a week on average, 4 2s are 8 for a month, then you're unlikely to get on a steep part of the curve. Now, there'll be people out there for whom 6 is a problem, and people out there for whom 12 is not a problem. That's humans, right? Because there's tall people and short people. But if you had to take a line, I would take 2. The other thing to say is, if you think you're worried about that, the thing you want to worry about is which preventive to get on, because the important thing about sliding as the frequency slides up is to start action on migraine prevention to stop things getting worse.
And so tell us how the Gepants might be one of those treatments that breaks those rules.
Yeah, the classic view at the moment, I alluded to it, is that you either have preventive medicines or attack medicines. That's what it is. You take propranolol to prevent migraine. You take sumatriptan to treat the attack. Okay. You don't take propranolol from time to time. Your doctor would say you're naughty because you're supposed to take it every day. And you don't take sumatriptan every day. Your doctor would say you're naughty because you don't take it every day. Okay. So that's crystal clear. With the that's crystal clear. With the Gepants, that rule is out the door, which is, at first you think, oh God, I know, and people go, oh, no. Have you been wrong all those years? Well, I hope not. But I think that by evolving this new class of treatments, you can get rid of the rule, because the treatments, this Gepants just attack the migraine process. They don't have other things going on. So you can take it once a week to treat your attack, great. Or you could take it 3 times a week to treat attacks, or you could take them every day for prevention. The more you use them, the better you get. We'd never say that with the triptan. So it's a complete revolution. And I think that what it starts to say is, we may be going to go into an era where instead of saying you need an acute treatment or a preventive treatment, you could just say, well, you need a treatment. And the treatment would fit you rather than you having to fit the treatment. So you don't have to worry, you wouldn't have to worry about whether, oh, what's this? Is it a preventive? Should I do this? Should I do that? Just take it when you need it. And it would work that way. And they would never have to, it would free people up from the scourge of having to fit their problem into a box, a physician box, as opposed to the medicine just sort of fits around you. It's all very, it's radical sort of concepts to do it that way. But I don't think personally it's that radical, but it's kind of radical in people's minds to say, well, the first thing you do is work out what a person needs, and you do the treatment based on what they need as opposed to what box you think they should fit in. It's a very radical change. But I suspect in a couple of years, when these things are more easily available, they're going to really change the way we think about treatment. You know, for example, if you're got some, say you're at university, you've got an exam period coming up, you may want to take this drug every day, no problem. But if you're doing otherwise well, you may just not want to take it for a few weeks. Fine and dandy. It's really it's a way of thinking about personalizing, if you want, the treatment in terms of frequency rather than fitting people into boxes. It's very exciting.
Thank you. Jane, Sarah, and Mandy all have questions about why the neck is so debilitating in a migraine attack, and for some of them, it's their worst symptom. How is that possible?
Yeah. Well, this will sound dumb, but it goes to the basic idea that there's just like one head. So the pain nerve centers in the brain, from the front and from the back, because they're all ahead, all go to the same place. So in the brain is agnostic. The brain doesn't really care which part of the head's involved, because migraine is fundamentally a warning. The system is a warning system. It's not a system that says, "I'll pull this bit out, I'll do this." It's a system that says bad thing is happening. Bad things happening. So the way these nerves are set up is that they don't actually know, much of the migraine system doesn't know where the actual pain signal's coming from, except it knows it's coming from the head, back here and back here. Consequently, neck discomfort is really, really common because this innervation at the back crosses over with the innervation at the front. So the warning is for the whole head. Neck discomfort is extremely common. We've looked at, there's a complex biology behind this that we've dissected out reasonably well. And it happens even at the start, in the premonitory phases, these brain mechanisms, dysfunction go awry. It's almost invariably, particularly in younger migraineurs, it's not a marker of pathology in the neck. It's simply a marker of how severe the problem is. The brain system for pain within the head was not set up to localize it, because you can't stick your fingers in your skull. It was set up as I can't read the mind of the creator, but I'm guessing that's why. But and obviously you can't stick your fingers in there. It's a warning thing. Because it's a warning thing, it's diffuse. It's like alarm bells going off. Get out of there. Get out of the house. It's burning. It's not an alarm bell that says just get out of that room because everything else will be fine.
Makes a lot of sense.
Pleasure.
Well, thank you very much for your time tonight, Dr. Goadsby. It's been an absolute pleasure. I've learned a lot of new things, and I've been watching a lot of your work, and it's always a pleasure to hear from you. And so on behalf of the community, thank you very much. For those in the chat, please join me in thanking Dr. Goadsby. If you have more questions, not to worry, we do have several more experts coming on throughout the week. We have Q&A time allocated for each of those calls. So but feel free to ask your questions there. But for now, thank you very much, everyone, and good night.
Good night.